Good afternoon, everybody. Welcome to UCSF Family and Community Medicine Grand Rounds. The title of our Grand Rounds today, which is truly a special Grand Rounds, is The Joys and Impact of Family Medicine in Birthing Care. I really want to give a special shout out today to our presenters, who all of whom are family doctors, many of whom are alumni of UCSF Family and Community Medicine, others of whom are not alumni, all of whom are doing an incredible job in making a difference for our patients, and some of whom are actually in clinic trying to finish seeing patients before they present today. So just as a reminder, today's session is recorded. If you would like to see today's session again, or you missed previous Grand Rounds, you are welcome to visit our website, UCSF Family Community Medicine. Just search under Grand Rounds, and there we are. All the sessions are uploaded. If you have suggestions for future Grand Round sessions, please let us know. I want to thank our tech team for today, who is John Tess and Roy Johnston, who's helping us keeping this session running. And we're really hoping that today's session will be an engaging and a conversation starter. So with that thought in mind, we're hoping that everyone can use the Q&A button to share your thoughts or comments with our group. We're going to have a lot of time for panel discussion at the end for folks to address your questions, hear your comments, and again, begin dialogue. For those of us who just joined us in the last couple moments, again, today's title is The Joys and Impact of Family Medicine in Birthing Care. Family physicians are uniquely equipped to address care gaps that contribute to our national maternal health crisis. In today's presentation, faculty in surrounding family medicine residency programs and former graduates from our program at UCSF SFGH will share successful models of perinatal care that incorporate family physicians into the teams and into the meaningful care of patients. Today, we'll hear about the impact that they are making on family medicine education and their impact in the communities that they serve, and what compels them to continue to provide birthing care in their careers. So with that introduction, I want to welcome our fabulous panelists today, and I will let Dr. Christine Pecci and the rest of the team introduce themselves. Thank you for joining us.
Hi, everybody. I'm really excited to be here with this great group of people. About half of the presenters today are family medicine residency graduates from our program, UCSF. And then the other half are my colleagues in family medicine OB education in the Northern California area. We meet about once a month to collaborate and to support each other. And we were really excited to come together to do a grand rounds to share our work with the greater family medicine community. We do not have any disclosures. Our objectives are to briefly talk about the gaps in the care of birthing people in this country, and then through our stories to highlight the unique contributions and impacts that we make to the care of birthing people. The presenters will review current models of care that robustly incorporate family medicine physicians in the care of birthing patients and their infants. And through our stories, you'll also hear and learn about some family medicine training programs that successfully train residents to join the perinatal workforce. It's really hard to enter this topic without at first acknowledging that how terrible our maternal mortality rate is in the United States. We are the second to the last bar here, and we are the worst rate in all of the high income countries. And unfortunately, you see this last bar here where we are really failing our Black families. This next slide continues to display the disparity we have in our Black families, but also you can see that every year, this is 18 through 21, we're getting worse in our numbers and not better. So we really do have a crisis, and it's garnered the attention of the White House. They published this blueprint for addressing the maternal health crisis in June of 2022. And the March of Dimes also has put some publications addressing what they call termed maternity care deserts. And why we have these deserts, it's really complex. It has to do with the closures of hospitals. It has to do with insurance issues and lack of access to care. But it also is a maternity workforce issue. And in their first report was published in 2020, and they stated that 1 in 3 individuals living in maternity care deserts are in urban or metropolitan areas. So that might be surprising to you. I think all of us realize that we have a crisis in our rural counties, but 1/3 of these people are also living in urban areas. In 2022, they have an updated report, and there's a new one in 2024. But I chose this one to share with you because in their original report in 2020, they talked about OBGYNs and CNMs, but they certified nurse midwives, but they left out family physicians. Like, oops. So anyway, in 2022, we have a new section in their report, and in their report, they shared these maps. So these maps on the left is OB and the right is family medicine, and the darker green areas describe a lack of access where there were no providers for patients. And as the green gets lighter, there's more access. So for the OBGYN side, there are 40% of counties without an OBGYN, whereas there are only 6.5% of counties without a family medicine doctor. In terms of sort of like the trends of where these providers are, for our OBGYN colleagues, there was a study done in 2017 looking at where people moved. And in a decade between 2005 and 2015, about a third of OBGYNs moved to urban areas or counties that had less poverty. There's also a trend for more of our OBGYN colleagues to go into fellowships and not necessarily remain in general practice. So we need all our types of providers, midwives, OBGYNs, and family doctors to increase and contribute to the workforce rather than decreasing. But we know that for family medicine, the trend has been decreasing, and you can see that graph there. I couldn't find an updated graph, but really like between 2016 and now, I think the rate has really stayed the same. About 6% of family physicians continue to deliveries. I'm going to hand this over now to Leah Suarez Abraham, who has had actually a long and interesting career in delivering babies in a bunch of different places. So I'm going to have her share her experiences with you.
Thank you, Dr. Pecci. I am, yes, as she said, Leah Suarez Abraham, and I am family medicine with surgical obstetric skills. And currently I'm core faculty at the new residency at Dominican Hospital in Santa Cruz. We just welcomed our first class in July. And I've been in practice for about 20 years now. And everywhere I've worked has been areas of OB-GYN shortage. So I'm going to share the real world examples of what Dr. Pecci was just describing. Next slide, please. So I was in Santiago, Atitlan from 2005 to 2007. Similar to many places in the world, Guatemala does not have enough physician healthcare providers to meet the needs of its population. And in this particular place, with a catchment area of about 40,000 people, there were no local OB-GYN providers. We did, however, have a retired OB-GYN from Utah who would come down intermittently to volunteer. And I was very grateful for his help and support. He provided some services that I could not. But his observation was, I'm not as useful here. You have the skills they need. And he was reflecting the fact that a family medicine scope of care, along with surgical obstetrics, met many more of the healthcare needs than he was able to provide and was ideal for the situation. Next slide, please. So after Guatemala, I went back to the place where I did my fellowship at West Suburban Medical Center in Chicago. And eventually I became the co-director of that fellowship. At West Suburban, family medicine obstetrics is solidly established, and we provided 80 to 90% of the in-house OB coverage. We were backed up by a smaller group of OB-GYNs who also had their own private practices. We, the family medicine obstetrics group, on the other hand, were employed by the local FQHC that served the west side of Chicago, and those residents were the majority of the population that the hospital served. And although there's no shortage of OB-GYNs in the greater Chicago area, there are certain places where they just opt not to work. The OB-GYN department chair explained to me that OB-GYNs wouldn't agree to provide in-house coverage at the hospital because the patients were too high risk. It was up to family medicine to care for the high-risk obstetric patients. Next slide, please. Now, although I'm faculty currently at a residency based out of Dominican Hospital in Santa Cruz, I work for the FQHC, Salud para la Gente, in Watsonville, and Salud provides the OB-GYN care at Watsonville Community Hospital, where the residents rotate for their peds and OB. So we care for a largely migrant farm worker population. And when I first started, it had been at least 30 years since family medicine providers had delivered babies at the hospital. And so they were understandably reluctant to give me privileges. Eventually, I was given vaginal delivery privileges, but then it wasn't until we had an OB-GYN who was going out on maternity leave and another one resigned. And that resulted in a staffing crisis. And then I was granted surgical privileges and I was integrated into the OB call group. And since then, despite having had OB-GYN job openings posted for the past 2 years, we've only been able to hire one more, and we've been filling the gaps with locums. We do now have another family medicine obstetrics provider, Dr. Rosalicia Torres, in our group, and Dominican Hospital has also hired an FMOB, Dr. Ashley Rubin. And although the need is there and our numbers are increasing, the model has been a difficult adjustment, and it still really hasn't reached maturity. So I would like to turn it over now to my colleagues who will discuss their FMOB models of care with good success.
So I'll come back and talk to you about Boston Medical Center, where I worked before I came to UCSF. There in around 2006, 2007, we instituted this collaborative model. And this is a graphic that shows, the 3 different types of providers. And traditionally, you have a patient who's a midwifery patient delivered by the midwife, family medicine delivered by the family medicine doctor. And so the significant part of this graph is these arrows that are going back and forth between these 3 different services. So we really sort of mixed it up, and we tried to redistribute patients because we had a very low volume service. So if there was obstetrics patients that came in that was low risk, they might be put over here on the family medicine service if the patient was agreeable. And we even, for example, would, if the patient was Spanish speaking, for example, and the midwife was language concordant, we would offer to the patient, would you like a, language concordant provider? So we really kind of like broke down these silos. We also had this mantra that we said, like, nobody sits until everybody sits. Sort of gone are the days where somebody's sleeping in the call room for 8 hours while another person is running around taking care of 6 laboring patients and 3 triage patients and like a postpartum hemorrhage. So you can see here that we really successfully redistribute the patients so that there were more deliveries done by family medicine doctors. And that was important to us because we were getting, we needed volume to keep our skills up. We also, more importantly, increased patient satisfaction. So you can see that when we started the model, we started talking about it in 2005, but really robustly put it in place in 2007. Patient satisfaction was better. And then the hospital was really happy to see that there were reserved claims against sort of unfavorable or bad outcomes with OB decreased over that time. And we did some other things. We did some teamwork and communication drills and things. So it wasn't only about family medicine, but definitely the change in role to make family medicine a more robust member of the team was really, really the crux of our collaborative model. It wasn't just that we were an extra body, but really also our expertise as providers and experts in the care of chronic medical conditions and our training in trauma-informed care really added an aspect to that unit that they didn't have before. And they have a patient population that's very much like our population at San Francisco General Hospital, a very medically and socially high-risk population. We're going to go down the coast from Boston to Philadelphia, where Dr. Betancourt will tell you what she's doing there.
Hi, everybody. Thanks so much, Dr. Pecci. Thank you for having me. My name's Renée Betancourt. I'm a graduate of the UCSF Family Medicine Residency program. I'm so proud to say that. I graduated in 2014. I did a chief year until 2015. And I want to introduce you to our Family Medicine Obstetrics leadership team. And you'll notice that next to me, I have a picture of a sheep because I am a follower on this team. Very joyfully so. So I'm presenting the successes of leaders in our program, including my colleagues and friends, Dr. Mario DeMarco. He is the director of our obstetrical program. Dr. Jenna Cohn is the director of the Promote Residency track, which is a unique family medicine obstetrical residency track. And then we have Dr. Naveed Roeder, who is the director of our perinatal opioid use disorder program. Next, please. So I'll share with you a little bit about our program generally. We have been working, our deliveries have been fluctuating, but we have been working on increasing them, and very successfully so this past year, and I'm exhausted, but so we are currently delivering about 12% of the hospital of the University of Pennsylvania. So that's one hospital in West Philadelphia. We're currently delivering about 12% of that volume with our 511 deliveries this past year. These are all deliveries attended by our family medicine obstetrical service, which includes physicians and 2 certified nurse midwives who are privileged as attendings on our service. All of these deliveries are attended by a family medicine OB resident as well. Next slide, please. So I want to share with you a little bit about where we're situated. Philadelphia, Dr. Pecci started this talk in discussion of the maternal mortality crisis, and it's really affecting Philadelphia as well. Unfortunately, oftentimes Philadelphia ranks as having some of the worst disparities and mortality for Black women in the United States. We can see that in the upper left, you see a picture of Philadelphia that shows that there's a large portion of the city lives below the poverty level. And then in the pictures of Philadelphia on the bottom left, those dots are showing you hospitals that deliver babies. And so there are 4 within the city limits that deliver babies. The one that has the pen shield, that's HUP, that's where we deliver. I was just being cute there. But before, there was some regulatory reform that happened in the 1990s, and that left us with 4 delivering hospitals. Before that, there were about 15 in the city. And so then in the middle lower, you see all of the stars. Those are the outpatient locations where the Penn Family Medicine OB team does prenatal care through memorandums of understanding with local FQHCs. So a total of 10 of us, 10 physicians and 2 midwives, in addition to are on the delivering team. Then we have 4 additional physicians who support us with our FQHC staffing, and we're all Penn faculty. Next slide, please. I'll share a little bit more. We have a total of 4 FQHCs with 6 sites. And then we offer one more site where a faculty member is directly employed by that FQHC, and then they also deliver on our team. So the prenatal care is delivered by our department by people who are actively delivering babies, and they are staffing the FQHCs. So I want to share with you I want to share with you a geospatial analysis that a medical student I worked with completed. So brilliant. And this is related to South Philadelphia. And if you go one more slide, this will kind of show you in the context of the big city photo. You see here that now we're in South and Southwest Philadelphia. And what we can see here is a heat map of outcomes like gestational diabetes, severe preeclampsia, and gestational hypertension. And so these are the home locations of the patients who delivered in a 6-year cohort, and the outcomes associated with the homes where they delivered. So we can see that our 3 Southwest Philadelphia locations are really right where some of the highest morbidity is. We'll go to the next slide. I'll comment on this heat map in just a moment. I wanted to share with you also that our total FQHC staffing is for physician staffing across those sites. We staff a total of 1.2 FTE. And for midwifery across those sites, we staff almost 0.4 FTE. So this was working with this medical student. She did this really interesting analysis. In the 5 years before the cohort, so the pre-partnership, this is the green circle designates the FQHC where our newest partnership, which is where all the extra deliveries came from, by the way, but our newest partnership was in that star green circle location. And so we see a heat map of where did the patients live who got their prenatal care before the partnership. And then we see in the first year of the partnership, some of the heat map, it sort of drifts down, and it suggests that access increased in the first year of the prenatal partnership in the South and Southwest area, which is a really key area of need in Philadelphia. And so what we're showing is that by upstaffing the GYN department of this FQHC, the population did shift and did move to a key important area. Next slide, please. Okay, so now I'm thrilled to share very briefly about the Promote curriculum. This is the residency track that focuses on obstetrical training. The goal is to graduate residents who are ready for independent practice at the time of graduation. So Promote stands for Primary Care Obstetrics and Maternal Outcomes Training Enhancement, OB. I won't go into the curriculum, but it's been developing over years. It's supported by a HRSA grant. It's generally speaking well reviewed by the residents, and the residents come out very well trained. If we go to the next slide, I'll share with you some of the impact on our community of practice from the Promote OB, from the presence of Promote OB. So we have our FMOB providers. In addition, there are those 4 additional FQHC prenatal providers, but our group is also, we do regular learning collaborative presentations to, spread and provide education to other non-prenatal providers. And so what we can see is that across different levels of institutions, inside Penn, outside Penn, among residents who are on the Promote track, but among all residents, among FMOB faculty, but also among all precepting faculty, we are doing our best to increase and enhance perinatal and reproductive knowledge and quality of care. Okay, I'm coming to a third program. So this is our perinatal resources for opioid use disorder. This is our PROUD program. And this is a program that provides care to perinatal patients from pregnancy through 2 years postpartum. It also provides dyadic parent and child care also through 2 years of life. And so our infant checks and well baby checks, all of those are also happening as dyad visits in this care. It's interdisciplinary care that takes place at Penn Family Care. And this is the city of Philadelphia's main opioid use in pregnancy program. There was another one at another hospital that shut down, and the OBGYN department currently does not. Currently, the OBGYN residents rotate at our clinic for this education, and there's no sort of corollary within the OBGYN department because our faculty were already doing this work. In addition, when patients are admitted to the hospital who are newly found to have opioid use disorder, who are pregnant on the antenatal service, for example, coming in for a microinduction, that is a consult to family medicine, and we provide the opioid use disorder consultory services in the hospital. So we just have a couple of years of data to share with you. We can see that we graduate a lot of babies who do not end up being maintained in the hospital related to neonatal abstinence syndrome diagnoses. And we're seeing some early signs that this has a great impact on emergency room admissions for these patients as well. We're really proud of this program. It's multidisciplinary. There are therapists. There's certified recovery specialists in all co-located at one time. And there are a number of levels of learners as well, from medical students, residents, fellows, up on to the attending. I think that's it for me. I'm thrilled to pass off to my colleagues and friends.
Thank you, Renee. So my name is Kyle Meehan. I am also a graduate and did the fourth year chief year at UCSF. I graduated in 2013, finished my chief year in 2014, and I'm going to co-present with now one of my colleagues, Nicole Person-Rennell, who also is a graduate from UCSF, graduated in 2017 and completed a chief year in 2018. And I had a brief overlap with her as I was finishing my chief year and she was coming in as an intern. And now we are colleagues together on our maternal child health service and in our mobile health program. So we're going to talk about both of those. We are at the University of Arizona in Tucson, Arizona. With the Family and Community Medicine Department. We now have a pretty large residency. We used to have 2 tracks. One was a rural like a rural track or had rural experience in the track, and the other one was located in Tucson the entire time. Those two programs have merged to continue the track, but under one program leadership. And so we are 48 residents, 16, 16, 16. And again, we have kind of this unique setup in that some of our residents stay in Tucson for the entire duration of their training, but others do a rural aspect of their training. And in that rural aspect, there are some OB rotations that they get to choose. We call them selectives because they do have to go on their rural months, but they can choose where they go. And so we have OB sites that are on the border between Mexico and Arizona in Nogales. And we also have training sites for OB care up in more rural, like mining towns in Arizona, as well as Indian Health Service sites. And so our residents do get exposure to OB care all over the state of Arizona, taking care of unique populations. And I think with that experience, we tend to graduate one or two residents every year that go on to continue to do maternal and obstetrical care. And often they're going to some of those rural sites where they did their training. So we now have residents that have graduated from our program that are now obstetrical providers throughout the state of Arizona through that rural program. We have a unique maternal child health service in that we have 3 clinics that feed into our delivery service, which is at the main university hospital. Those 3 clinics are residency continuity clinics. One of them is a Banner, where the University of Arizona is now affiliated with Banner Health. And one of those clinics is our Banner Health residency clinic. We also now have another residency clinic that is a federally qualified health center here in Tucson that we see obstetrical patients through. And then we have a mobile health program, which I'm going to have Dr. Person Renée talk about a little bit more. All of those sites it's a little bit chaotic in terms of our obstetrical care, similar to what Renée was referring to. We have like multiple EHR systems and multiple different scheduling systems to get our obstetrical patients scheduled. And we do serve all of Tucson and different neighborhoods depending on where the clinic is located. Our clinics then have our continuity patients come in, and we run a service that while our residents are doing deliveries and obstetrical care, they are also doing newborn nursery and taking care of the patients that come in. So we do dyad care, as well as we are alternating with our pediatric colleagues, accepting newborns that were unassigned or were not taken care of by us during their prenatal care and delivery process. So I'm going to hand over, because I think one of the most unique aspects of our care is our mobile health program. And Dr. Person Renée is the medical director for this. I will say that about 50% of our delivery volume comes from our mobile health clinic. And so Dr. Person Renée is going to explain a little bit about Medicaid in the state of Arizona, which is unique and provides some challenges with our pregnant patients.
Hello, good afternoon, good afternoon. I'm Nicole Person Renée. I am the medical director for the mobile health program. And just in a minute or so about this program, we provide clinical care for patients who don't have health insurance for pregnancy. And so Medicaid is administered, as you probably all know, by states in a fashion that they can choose. And so in Arizona, our state-based insurance only provides coverage for the hospital for folks who may lack other forms of documentation, and doesn't cover any prenatal care, unfortunately. And so we try to fill that gap, identifying with what Dr. Pecci described as a March of Dimes maternity care deserts. We are in a desert in Tucson, and then in particular serving a patient population that has essentially zero access from a cost, transportation, and other barrier-based system. So the clinic has been around since 1976 with Dr. Augusto Ortiz and his wife, Martha. They were friends of Cesar Chavez. We pulled in an article here for interest, if you'd like to learn more. And the mission since that time has been to really provide critical care and access for a diverse community in Southern Arizona. We have continuity sites and provide family medicine care all around Tucson, and in particular provide a lot of prenatal care in this particular niche or access area. We pulled in some of our information, but in 2023, 100% of our patients lacked insurance for prenatal care. We do have a few folks that we see who have catastrophic only insurance, and we will see them because that doesn't cover prenatal care as well. Oh my goodness, my micro text here on my phone, I'm so sorry. 95% of our patients identified as racial ethnic minority groups, and then 72% had household incomes below 30% of the Arizona median income, which is one of the metrics we use for grant reporting. It just signifies a significant level of socioeconomic disadvantage. So this program has really allowed us to fill a gap, and then for both Dr. Meehan and myself to continue our work in family medicine with obstetrics and deliver those patients. I have a patient that I'm discharging today from the hospital who just delivered with us and is doing great. I'm going to keep it moving and turn on to my colleagues.
Hi, everybody. My name is Amanda Kim. I am a graduate of UCSF in 2018, and I pursued a surgical OB fellowship afterwards up in Seattle, which is kind of where I stayed. And so now I'm faculty at a residency program about 20 minutes south of Seattle. We're suburban, small class of 8 for each class, and it's a community hospital solo residency. It's interesting that even though we are in the suburbs, and it appears that you would have suburbs conveys a more financial stability situation, but our patient population happens to be anyone who can't afford to live in the city of Seattle and therefore can't access the care that they need, especially for maternity care services. I started in my job as a OB. I'm a laborist for the hospital. I work for the OB offices as a laborist in the hospital, but also as core faculty where I also deliver with the residents all of our family medicine patients. A kind of the reason I was able to get started in this high, I guess, not currently a maternity care desert area is because at the time, a bunch of private OB offices were collapsing, which has kind of been a trend in recent times and getting absorbed by larger community hospitals. And patients are really finding it difficult to find the level of care they need in terms of continuity care. And so what family medicine provides is we guarantee a continuity provider, someone you know, and who will also have that long-term relationship with you with your children. So recently we've been taking a lot of new patients from Ethiopia and Ukraine with the current conflicts and having to take them late transfer, which we will accept because we also have to care of all their children, whereas a lot of OB offices are declining based on their late term pregnancies. And so that's a service that I feel like we are uniquely positioned to provide. My job, for those of you who may be considering obstetrics with family medicine in the future, as faculty, involves home call once a week. I do inpatient obstetrics, medicine, and pediatrics, and I also have services during the weeks for those. In the office, in my clinic, and when precepting our residents, we offer office medical abortions, manual vacuum aspirations, colposcopies, vasectomies, circumcision, and all our usual family medicine procedures. So really our training and practicing as full scope as we can in Seattle area. Next slide, please. This is a little bit about what our graduates in our program are doing. We've really made an effort to increase the obstetric volume for our patients and also on behalf of our graduates. So in the last 4 years, our median number of vaginal deliveries for graduating third-year residents has been over 100. But most of the residents now have over 100. You can see in last year, one of our graduating residents had 165 vaginal deliveries, increasing some C-section experience as well as more of our graduates go on to do obstetrical surgical fellowships. And what we are really focusing on is creating an increased continuity experience for both our patients and our residents. So we've been able to increase that as well. If you are interested, by the way, in joining us as faculty, I have a job link there, but otherwise I'll open to questions on the panel. Thanks.
I'm Rebecca McEntee. I am also a graduate of the UCSF Family Medicine Residency Program. I finished in 2008, and like many of my colleagues here, stayed for a fourth-year chief year, ending in 2009 as well. Since then, I've actually been working I have wear a few different hats, but my main hat has been as a family medicine OB provider at La Clínica de la Raza. I think we are the only non-academic setting. We're sort of academic adjacent being discussed today. So La Clínica is a network of federally qualified health centers in the East Bay area, in Alameda, Solano, and Contra Costa counties in the Bay Area. We have been doing family medicine obstetrics for at least the last 40 years. When I tried to find out the exact year, nobody can remember exactly when because it's been so long, but since the early 80s. And our structure is a 24/7 staffing of an OBGYN and family medicine doc dyad. The family medicine doc is the one who really runs the service, and the OBGYN role is really meant to be a consultant or doing things that are outside the scope of the family medicine doc who's on call. Our group is about about 15 family docs, and we're a mix of folks who are fellowship and non-fellowship trained. The majority of us did not do fellowship training. We do about 900 births per year. Our scope in obstetrics, is most, like we call it, kind of low to medium risk obstetrics. So as an FP, we're managing a lot of the complicated things that happen during pregnancy. We're surgical assists during C-sections, if we're not fellowship trained, and primarying if we are. Our service does about 900 births per year. And the reason I joke about being academic adjacent is that we have partnerships with 2 of the local residency programs, UCSF and the Lifelong Medical Care Family Medicine Residency, where I'm also faculty, to have the residents on service with us. So we do have the opportunity to do teaching. And in terms of data, we don't have a ton, or we don't do a ton of research. We probably should, but the 2 things that we have seen over time are really positive feedback from our patients about their care experience, and then also the retention rates of our providers. It's just, we're seeing people in clinic, they then come to see us in the hospital. Our pediatricians see the babies. We're just a very closed loop system that has a lot of great continuity, and that I think has been a bonus for people, especially folks from vulnerable and marginalized communities over the years. And then our high rate of provider retention. My little straw poll, looking at the people in the group right now, of the 15 of us, over 10 have been there for more than 10 years, and over 5, and I think 12 of the 15 have been there for more than 5. So we have pretty high rates very high rates of retention for the folks who are doing FMOB. In terms of data that we do have available, what we can see, this comes from our delivering hospital, which is Alta Bates Medical Center in Berkeley, California. And so they track many things, but one of the things that they track is our NTSB rate. And so you can see the lines in the graph are the trigger points for Sutter and for their goals for NTSB. And then you can see represented both numerically and visually are La Clinica perinatal NTSB rates, which are much, much lower than the hospital average, and kind of help to keep the hospital's average down. So that's for the last year. These are the last 3 years. So you can see that it's a trend that our service, you can go to the next slide, Christine, that our service is consistently a lower rate than the overall hospital. And, I can't say that that's causal, but we like to believe that it's correlated to the fact that there's family medicine folks involved in the care of these patients and the continuity that our service can offer. And so now I am going to pass it off to our colleagues in the Greater Bay Area to discuss some of the exciting things that they're working on.
Hi, my name is Hannah Watson. I am the maternity care director at the Sutter Santa Rosa Family Medicine Residency. I did my residency at Boston Medical Center, and we're going to talk a little bit more about mentorship. I want to particularly thank Christine Pecci for inviting me and for hosting this discussion. She was one of my attendings as an intern and a reason that I got into this work. So our residency program is a community program in Sonoma County with 12 residents a year. We're a partnership between a federally qualified health center called Santa Rosa Community Health, where residents have their outpatient OB experience and continuity clinics, and they do deliveries at Sutter Santa Rosa Regional Hospital. We are at a high volume OB practice. Our residents graduate between 70 and 120 deliveries a year. And many years there are graduates who go on to pursue an OB fellowship. Next slide. We can go ahead and go to the next slide. Great. So this is just looking back at the residency graduate survey over the last 5 years. And our residents have a high volume residency experience, and many of them then use those skills to go on to provide care for birthing people after residency. So 43% of our residents in the last 5 years are currently delivering babies. And many of them are doing both attending vaginal births and C-sections. You can go to the next slide. I think one of the keys to success is our volume and risk that residents are exposed to in residency. So our residents felt like 100% of them felt that they were well prepared to practice maternity care. And again, you can see that about 2/3 of our residents are practicing some form of prenatal care or OB. And then almost all of them are doing other reproductive health procedures, and about 1/3 of them are providing abortion services. So a couple things that we've found to be factors for success. One of it is volume. So the federally qualified health center that we work at has a large prenatal practice with over 700 deliveries a year. And family physicians attend more than half of the births at our hospital. Our OB call team includes residency core faculty and community attendings, and there is a mix of surgical and non-surgical training on faculty. I think another factor for success is that there is a legacy of family doctors attending OB here in the community. And then once you train here, you can stay here. So there are 5 FQHCs, at least in Sonoma County, where family docs are providing OB care. Our local Kaiser affiliate has 2 FMOBs who are surgically trained and doing deliveries there. And the Sutter Hospital also employs FMOBs. With that, I am going to pass it along to Kaiser.
Hi, everybody. I'm sorry, I'm having a hard time starting my video, but my name is Gabe Flaxman. I'm the Associate Program Director for the Family Medicine Residency Program at Kaiser Napa Solano area, which is mainly housed in Vallejo. We are a newish program, and we just graduated our 10th year of residence. And so we'll talk a little bit about the hospital in terms of the model and a little bit about the residency. Thank you for that slide advance. So the Vallejo Medical Center is one of the hospitals in the Kaiser Northern California medical healthcare system, which is quite large. For those of you that are local, you're probably aware of it. For people from somewhere else, Kaiser's a big entity in the healthcare world. And Kaiser Northern California has about 27 hospitals. Not all of them do obstetrical care. And there are about 4.5 million Kaiser members. Vallejo is a unique Kaiser center in that there's no county hospital, and the payer makeup for Kaiser Vallejo is about somewhere around 20% Medicaid. And because there's no county hospital, we take lots of walk-in patients. It's a pretty high risk level 2 center in that for Kaiser. And so it's a lot of bread and butter, high risk social determinants of health, so substance use and preeclampsia, diabetes, obesity, but we're not a level 3. It's a good place for people to work and train. The numbers in terms of deliveries vary quite a bit. It's about 120 deliveries a month in Vallejo. I was on last night and we had 7, so it can obviously be a fair bit busier. Our system is different in that there's not multiple groups of people admitting to the same hospital. So we have one team. There are 32 OBGYNs. There's currently 1 surgical FP, myself. We have 10 non-operative family docs and midwives. And so the call structure is 1 surgeon, 1 non-operative clinician, and a resident for each 12-hour shift. When you're not taking call from home or in the clinic and running over to deliver babies. So it's dedicated kind of hospitalist model. And in terms of the residency, like I said, it's a newer program, 666. We have about 60 graduates. We have what's called an OB distinction, which is a focus for residents that are interested in obstetrical care after graduation with stricter expectations for delivery numbers and proficiency. Next slide, please. In terms of our 60 graduates, we've had 1 who pursued a surgical fellowship and is currently providing full spectrum OB care in a rural FQHC in Georgia. We have 1 of our OB distinction residents who went on to provide non-operative OB an Indian Health Service in Northern California. 3 graduates who stayed on with us to do non-operative OB. And we have, which ends up being about 15% of our graduates doing inpatient OB from our program in the last 10 years. Graduates are all over the place doing prenatal care. So happy to talk more about Kaiser later if you have questions.
I'll unmute myself. Okay. I don't think my video is coming through. I'll just keep going. I am trained at Ventura for residency, and I was born and raised in Fresno. And so for 12 years, I worked in private practice and covered call for a group of 5 OBGYNs as well as my own patients. And then a year ago, I joined faculty with UCSF Fresno in the family medicine residency. So our program is a little bit in its infancy again with OB, because we used to do large volume OB deliveries at a small rural hospital and lost our affiliation with that hospital, OB deliveries there. And so now we've restarted our program at the large teaching hospital, which is a opposed multidisciplinary multi-specialty teaching hospital in Fresno that does about 400 deliveries a month. And so we have 6 family medicine faculty who are non-operative OB faculty, and they cover our FMOB service. And then our OBGYN faculty are our backups for deliveries. We admit all of the newborns delivered at that hospital 3 days a week, and our pediatric colleagues and residents admit the other 4 days. So our service consists of newborns as well as our OBs that come from 4 of the outpatient clinics. 2 of those clinics are rural, and then 2 are within Fresno, are urban. And then we're beginning to build and co-manage more complex patients with our OBGYN colleagues. And so we utilized the Boston Medical model because we do have an OBGYN service, we have a family medicine service, and we have a nurse midwife service. And so we've used some of that model to integrate and to really improve our numbers and improve our experience in managing OB patients for our residents. And then also developed a monthly case conference to help support our faculty. And so we improved our deliveries from about 5 to 10 to about 25 to 30 deliveries per month. And then these are where our clinics are located. The majority of our OB patients come from this rural FQHC faculty clinic in Mendota, which is on the western side of Fresno County. And then we do also this year just signed a contract with United Health Centers as the preferred provider for their 38 clinics that they have in and around Fresno and throughout Fresno County. You can go to the next slide. So Mendota is a unique population. It's very rural. It's about an hour from the delivering hospital, which is in Fresno, where we deliver. And it's primarily a farm worker population. There's a lot of high social determinants of health. The health equity metric, they score very low for health opportunities. They're in the highest quartile for cardiovascular disease, diabetes, and asthma, all of which affect our OB population, and then a high poverty level. So there's some unique teaching that we have with our residents there. And then we do have a robust perinatal substance use treatment program. I chair the Perinatal Substance Use Task Force for Fresno County, which is a collaboration between the Department of Public Health and California Health Collaborative. And we bring together a multidisciplinary team once a month to help get our pregnant patients who struggle with substance use into care. We also have 2 faculty who run the addiction medicine consult service for our large hospital where we deliver at, and they see both adults and pediatrics and OB patients with substance use. And then we have also outpatient harm reduction clinics within a lot of our faculty clinics and resident clinics. And with that, I will turn over to John Muir.
Hi, I'm Audrey Arai. I finished residency at UCSF in 2015, and then I did a surgical obstetric fellowship at Santa Clara Valley in San Jose, California. And I currently lead the OB curriculum for the family medicine residents at John Muir Health Family Medicine Residency. And I won't go through everything I plan to say because I know we're short on time, but I will focus on the fact that our residency is low volume obstetrically, but our residents do end up caring for very highly complex patients and will routinely manage patients with diabetes and hypertensive disorders of pregnancy, and will titrate insulin and antihypertensives in consultation with maternal fetal medicine. And we also, less common than diabetes or hypertension, will manage patients with seizure disorders, renal disease, lupus. We have a couple of patients who have been HIV positive, histories of cancer, hypothyroidism, and then surgically complex patients with histories of C-sections, myomectomies, that type of thing. But I really want to focus on my second slide, which focuses on the fact that our clinic does increase access to birthing people who are living in Contra Costa County. You can see here an outline of the county itself. It's home to a population of about 1 million, 200,000 of which rely on a form of county-sponsored Medi-Cal health insurance called CCHP. And for patients with this Medi-Cal insurance, their options for delivery are these 3 hospitals, one of which is not even in Contra Costa County. So it is geographically prohibitive for many people. We love Alta Bates, but it's just too far away for many of our patients. You can see up north that Contra Costa Regional Medical Center, they do carry the bulk of deliveries for Medi-Cal patients in the county, but they have a level 2 NICU and their own resources are often stretched. So what our residency can do is we can see and take on patients with Medi-Cal in our clinic as prenatal patients, and then we've contracted with John Muir Walnut Creek Hospital to deliver them there. And that's a very unique service because the John Muir Walnut Creek Hospital operates on a private practice model, and we share the floor as a residency with 7 or 8 private practice groups who as a whole do not take Medi-Cal insurance. And so coming to our clinic and receiving their birthing care, prenatal care, and then their birthing care with us at John Muir Walnut Creek, and then usually dyad care postpartum with their babies at our clinic is a way that we can help, open up another option for care for the birthing people who are living in Contra Costa County. And I'd be happy to talk more about this, but I will pass this on over to the next presenter.
Okay, so just bringing it back to UCSF in San Francisco, I'm going to just take 1 minute to wrap it up. But our residents go to FQHCs, academic health centers, and government clinics. They do a lot of care in contraception, reproductive health. And this number, 56% do maternity care. That's like everything, including prenatal care, which is why that's such a big number. But we also do have greater than the national average, which is here in dark. We're the light blue. We do have more residents compared with the national average doing deliveries. And I think it's because they go to areas of need and they are delivering 35 and vaginal deliveries and 30 C-sections, which is like annually, which is a good number to have to keep up your skills. So just to summarize, the summary is there. We do have some robust training programs that are close by. You don't need to go to the middle of the country. Hopefully we've convinced you of our value and our essential role in the care of birthing people and their newborns. And our ask of you, which is one of the selfish reasons why we want to do this grant grand rounds, is if you all, because you all serve as mentors for students and residents, if you all can encourage those who are interested, we're not trying to get people who aren't, but we want to increase our perinatal workforce in family medicine. So please send them to us so that we can talk to them about our work, encourage them at least to explore and look into it. And thank you so much for being an advocate for your colleagues who do this. I think a lot of us are doing this and continue to do it because we are being supported by our colleagues, like all of you and our department chairs and our institutions. So we really, really appreciate the support that you give us.
And I want to I'm hoping all of our presenters could come on camera. Of those of us who are able and not in the middle of seeing a patient, maybe could come on camera. I just want to give a huge thank you and lots of love to our presenters today and all the work that you're doing for our patients, our birthing patients, for their babies, and serving as role models. It's incredible to see such a wonderful group of folks today, especially with so many alums doing amazing work. Aside from my most heartfelt thanks, I also wanted to express the fact that this grand rounds ran really long. We didn't have time for comments and questions. I would encourage everyone who's watching this to please reach out to our presenters individually with your thoughts, your questions, your interests. We're always excited to talk to students, residents, or anybody who wants to get more involved in this process. And again, it's a feeling of abundance to see so many people here that we actually ran out of time. That to me is just a great starting point to work further into this conversation together. So thank you to all our presenters and thank you to everyone who joined us today. Appreciate it.
Thank you, everyone.